If you look at this slide, the thing that I find incredibly interesting is that the blue area represents what the government spends on healthcare for all of these different countries. And if you notice, the United States government, including federal, state, local, city governments, spend more money on healthcare per capita than any other country in the world. Yet we still have 45 million people who have absolutely no insurance at all. And obviously, a lot of the costs associated with healthcare, the high costs that we have compared to other countries, are made up by out-of-pocket costs and employers spending money on those, on health. Look at the next slide, is what value are we getting? We spend all of this money, and we wonder, are we getting really great value? I like to go back to thinking about what American cars in the 1970s, for example. Right. If any of you are old enough to know about the cars in those 1970s, you know that those cars were, frankly, really terrible. But today, 21st century cars, whether made by GM or others, whether they're made by foreign manufacturers here in the United States, they're high quality cars, they're really good values, but the 1970s cars were awful. I start to look at the statistics on this slide and I start to wonder, are we really getting great value for our healthcare? It makes me really concerned. Now, looking at this slide, what this is showing you is it's saying, what's the ability of healthcare to prevent premature death in people 75 years of age or younger? And as you can see, the US is doing worse than all of these other countries, yet we're spending so much more money per capita than any other country in the world, which makes me think we have a 1970s automobile value healthcare system. We spend a lot of money for things, but we're really not getting what we need. Right. You know, you brought up the comparative effectiveness, and that makes me absolutely crazy, and I'll tell you why. Okay? I graduated medical school like 30 years ago. You know what we used to call comparative effectiveness? Medical research, right? Don't you want to know what works and what doesn't, and then apply the things that work and not apply the things that don't work? I mean, that's what medical research is. Sure. Yet we've now got this term of comparative effectiveness, and it's supposedly bad. It's not bad. We should know what works best, and you know what? It's our obligation in healthcare, all of us in healthcare, it's our obligation to apply what is the best practice and utilize it, whether it's the best practice in clinical decision support, what we're supposed to do. It needs to be evidence-based, and we also have processes to make sure it's delivered in the best way possible so that the most people can receive that best care. We know what works in so many areas, but we don't do the necessary things to make sure all of your loved ones get the best possible care.
Because the team, by the way, the team sport is, I think you said it earlier today, the patient is at the center of that team.
Absolutely.
They're in the huddle. I mean, they're part of this. And I think that's also, again, maybe you're the physician here, so part of the training and all that, the patient, the physician, there was a different relationship there. We want the patient and the families. Now we have the extended family, because getting them all engaged is part of this. It's going to be it's a terrific opportunity to change how healthcare is delivered. However, it's going to require a whole different set of thinking.
Absolutely, and I'm so glad you said the patient-centered, because we know about patient-centered medicine, patient-centered healthcare, but we can't deliver that unless we have patient-centered workflow.
Great point.
We have healthcare systems, IT systems today, that are not about the patient, not about patient care, not about facilitating the clinicians and the other people who support those clinicians to get them to do their job. Great. And we have to change that information technology tools that they use so they can learn them quickly, they can apply them, and they can be patient-centered. Think about this simple little concept. Imagine if we had lab results or actually results on a patient crawling across the bottom of a screen that you would the way we see sports scores or news, and that was available to everybody who was responsible for caring for that patient. Maybe it would work, maybe it wouldn't work. I don't really know, but it's a concept. Maybe we throw it over to the hook and loop people, see how they run with it, and see how it would work.
Exactly.
Maybe we need to build in that interoperability to be able to accomplish that. But it would be interesting to see, would it help support patient-centered workflow? Will it make a difference?
The ability to connect different systems as well as engaging a population, I mean, many of the same topics that you see here, that's top of mind for everyone who's out in the audience.
Steve, that is so critical. How can a physician, how can any clinician treat anybody unless they have all the information about that patient? How can they treat you? They can't. And you know what we end up doing? We end up ordering another test, another procedure. We subject people to some level of discomfort when we do that, or radiation. Why? Because we can't get the data about them. That's crazy. Yep. In this age, we can get data about everything we want in all these other industries, but we can't get that data in healthcare.
Absolutely.
But it's changing. It's absolutely changing. I'm confident that we're getting there. We're on a path to make it happen, but we really need to make it happen. You know, we have to work really hard to make sure the IT is useful for those patients and it's accessible. They know how to use their Android or their iPhone. They know how to use a tablet. We have to be able to get that information in their hands in a way so that they can be consumers. Because if we don't mimic, as you said, or copy the things that have been done by all these other people, Apple, Google, and others, in using technology, we're not going to be able to engage that consumer and allow them to even have a role. I think we're getting back to the discussion we had around value. And Steve, you talked about true cost, Infor true cost.
Absolutely.
It's really trying to understand what things actually cost. If we link that to some of the things you've said, Chris, around outcomes, clinical outcomes, wouldn't it be wonderful if we knew we can produce this particular outcome in these patients and we knew how much it costs to do it, and even better, we can replicate it again and again and again, so we can talk to people, we can talk to our community, and say to them, we can do this. If you come and visit our hospital, we can do this. We know how much it's going to cost. We know what these outcomes are going to be in this particular population, and we're constantly measuring it. We're doing the analytics on it, we're collecting the data, and we can iterate it to make sure we get a little bit better each time, or we're using that surveillance, right, to measure how we're working, so if we're a little bit getting off track, we can come back and re-steer the ship.
See what happened right there, Steve? Barry's getting crazy on us here. He's talking all these like ideas. This environment we're in with innovation. Look at you. You're like, you know, we're going to bring it all together. But seriously, you're absolutely right. It's about how do we bring those two together, because that's really what we're talking about in all this.
Right, and we need to be able to tell people what do things actually cost. Not only the people who are providing the care, but also the consumer. This is what it actually costs. For many people, it's out of pocket. And they need to know, am I getting good quality care and how much am I paying for it? And you're probably seeing the same statistics I have. Some of the most expensive costs for a particular procedure are in those hospitals that have the worst outcomes.
Well,
so we have to go ahead and figure out, can we do things efficiently and effectively, what's best practice, and apply it, and also be able to tell consumers what they should expect from the dollars they're spending.
do that, but I'm also concerned, like, well, how do we really get everyone to work together in this seamless way that, quite frankly, go back to your first graphic, that we're demanding people do? We can't sustain this cost increase.
Well, you know what? The first thing we got to do is have to create a platform that people actually can work together. You know, we struggle with that platform today. Most physicians I know don't read nursing notes. I don't know how many physicians or nurses there are out there, but if you think about it, how many times you're reading a physician note, or clearly nurses read physician notes, but oftentimes physicians don't read nursing notes, and that would be really valuable. And how much time do we spend doing documentation and other work that we wonder, is it really beneficial to the healthcare of that patient? Does it really help to move them along? Or was the data that we're entering just there for, as we were talking earlier today, about coding and reimbursement and such, which hopefully with the reforms that are coming won't be as important anymore, and we can focus using the information technology on healthcare. Absolutely, absolutely. Everybody is involved in healthcare and making it patient-centered. It's the physician, it's the nurses, it's the orderlies, it's the janitors, it's the technician, it's the supply people. It's this whole concept of a health supply chain, not a supply chain of products and goods, but all of the things that go in to making sure a patient gets well if they're sick or stays healthy if they're healthy.
Mean to get to this next new normal.
I don't know any patient who really cares about silos. What they care about is getting good patient care, getting healthy, being well, being with their loved ones. They do not care about silos. And if they knew about all these silos, they knew about the fact that the information couldn't be transferred, I doubt that they'd be very happy about it.
No, not at all. I grew up in Wisconsin, so silos means a different thing to me. So there's a lot of people who are very positive about silos. But to your point, the idea of, I mean, these people aren't having coffee together. They don't park in the same lots. They didn't go to school in the same places. So those experiences, in addition to the healthcare system being bifurcated at the different points that it is today, just puts that burden on the consumer, no longer just the patient.
You know, it's really interesting. Physicians and nurses never get taught together. The first time they get to work together is when you're a third-year medical student. Okay? You get thrown on the ward, and all of a sudden you have to work with all of these people, to take care of a patient in a very complex environment, because people in the hospital today are much sicker than they were 10, 20, 30 years ago. Sure. They require a lot more care. And we have to all work together. We never were taught to work together. We don't get an education together. But yet really is a team sport. It's really a team effort. I think information technology is incredibly valuable and could be incredibly important in taking care of patients and providing good health care and providing it in an efficient way. But we have all this IT, and it's used incredibly well in other industries. But it's not used that well in our industry, or at least it could be used better in our industry. And what I believe I think we need a bit of innovation. We need to think about, can we take the technology that we use today in healthcare and create it, modify it, innovate it, so that it functions and works the same way that we use technology in our personal lives? I think that can be incredibly invaluable. Why? Because then we can get so much more value out of the functionality that's inherent in that technology.
Not necessarily Infor, but some of the more specialized EMR capabilities have been somewhat proprietary, kind of closed systems, didn't talk with each other. In your career, how have you seen that evolve? Are we still there in a lot of ways? And how is Infor really going to try to affect change in this industry, which obviously is important to everybody?
When I look back on my career, I've been saying I've been waiting for this moment for over 30 years. For 50 years, this country has basically had a system where we incented people to do more things, but not necessarily focus on delivering better patient care. No, it's true that we can get some very good patient care in the United States, but it's also very expensive. We have to do something to be much more resourceful in how we use the limited resources we have, 18% of GDP today, and how we apply that to deliver good outcomes. If you look at some of the data, we spend a lot of money and we get really crappy results that we would never ever put up for in any other industry, but we have been dealing with that in healthcare. But the world's changing, the reimbursement is changing, the incentives are different. Now people are saying, I'm going to spend this money on healthcare. What type of value am I getting for it? You're hearing that from the providers, you're hearing that from payers, you're hearing that from employers who are self-insured, and then you're also hearing that from consumers. So what the incentives before were, we don't want to talk to each other, because if we talk to each other, then we'll have more data. If we have more data, then we can't order that next test. That whole world of those perverse incentives are gone. Now people want to be able to share information, integrate. And I have to tell you, if anybody has a family member who has cancer, they have cancer, it's really important for them to look to someone who can explain to them what all the words mean, what the journey might be like. And I want to emphasize also that when I started medical school, cancer was a disease that killed people. All these years later, because of the work that Dr. Dorosek has done, Dr. Castillo has done, all the wonderful people that Dana-Farber have done, it's now becoming a chronic disease.
We use the phrase cure cancer probably too much in our lives. Curing cancer may not be what we're talking about in your particular instance, but what we are talking about is giving you a longer, healthier life.
Exactly. We don't cure old age. We don't cure congestive heart failure, right? We don't cure high blood pressure. We live with it, we treat it, we extend people's lives, we improve their activities of daily living, we improve the ability for them to be social, to be with their family, to see their children and their grandchildren and even their great-grandchildren. So cancer isn't something that is an end. It's just one other thing, one other bump in the road in your life that you go over with your bicycle or with your car, or you walk over and you deal with the same way you deal with hypertension or any other diseases. I'm not playing down that in some cases cancers can be quite brutal, quite aggressive, quite painful for the patient and their family. But in many, many cases today, unlike 10, 20, 30 years ago, it is that chronic disease that we will be able to live with.
And tell people why they should make a donation.
The reason why you need to make a donation is because your money goes to the Dana-Farber for creative, young researchers who have an idea about how to address cancer, but they don't have enough evidence to convince the National Cancer Institute and National Institute of Health to be able to get that big grant. Your money allows them to do that
individual small study that shows promise, that leads to the multi-million-dollar grants, which leads to all the wonderful research that is converted in my time as a clinician from disease that killed people to a disease that has now become a chronic, where you can be treated and live a long and healthy and prosperous life with a chronic disease.
Currently, the U.S. spends about 18% of GDP, close to $4 trillion a year in healthcare. That is about $11,000 per person living in the U.S. Our neighbors to the north, Canada, spend about $5,000 per person. So what do we get for all that spending? It surely must be the best care in the world. According to the Commonwealth Fund, the U.S. has the lowest life expectancy among the 10 highest income OECD countries. We have the highest chronic disease burden, and our obesity rates are twice the average of other OECD countries. We also have the highest number of hospitalizations from preventable causes and the highest rate of avoidable deaths. To me, that sounds like we spend a lot of money on healthcare, but we're not getting a lot of value in return. So how did we get here? Why is our healthcare system more expensive than other high-income countries? And how do we build a system where health insurance is tied to our employment? Why do we not have a system like most other countries where our healthcare services are guaranteed by the government? The answer to that is linked to World War II. But let's start at the beginning. The first healthcare plan was established in 1929 in Texas, when Blue Cross was created to allow teachers to pay a hospital 50 cents a month so that when they went to the hospital later to have children, they did not have to pay for the cost of their care. Blue Shield was later created to cover physician expenses. Fast forward to the late 1940s when the U.S. was converting its war economy to a peacetime economy. During the war, there were very few consumer goods, so people saved much of their income. Once the war ended, consumers wanted to spend their savings. At the same time, there was a shortage of workers to manufacture the goods people wanted to buy. To prevent runaway inflation, the government instituted wage and price controls. As companies could not keep or attract workers by increasing wages, they expanded the benefits they offered. One of those benefits was healthcare insurance. During the Truman administration, attempts were made to pass a universal healthcare law, but the effort failed in Congress. Employee healthcare insurance did not become a significant cost for companies until the 1980s. It was only then that expenditures started to make a meaningful dent in corporate profits. This is when schemes emerged to control costs. These include health maintenance organizations that limited where a person could receive care, pre-authorization requirements for certain expensive services, and deductibles and co-payments that shifted some of the costs from the employer to the employee. So why did costs start to rise so quickly in the past few decades? There are many reasons, including the technological advances in medical devices, breakthroughs in drug development, and the aging population. When I was in medical school, computer tomography or CT scans were the latest technology, while MRI scanners were experimental. Today, MRI machines are everywhere, even in privately held imaging centers. The original mapping of the human genetic code cost over $1 billion. Today, it can be done for less than $1,000. Medical advances are occurring at an increasingly rapid rate. For example, we developed messenger RNA vaccines delivered in polysaccharide containers developed in less than a year that are safe and over 90% effective. And the first vaccine prototype was built by a computer in just 2 weeks after receiving a data file containing the 30,000 base pair genetic code of the coronavirus, something the Chinese published on the internet in January 2020. Each medical advance is associated with a large investment in R&D, which companies need to recoup from the sale of these new products. But just because a product is new doesn't mean it is better. Yet we jump to these new products and modalities not paying enough attention to the incremental value compared to the incremental increase in cost. And with all this technology, we're unable to produce healthcare outcomes that match all the money we spend on care. There are several reasons for this. First, no one knows what it actually costs to provide a particular service. Organizations do not know what it costs them to do hip replacement surgery, treat a heart attack, or set a broken leg. So how is an organization able to evaluate whether they are efficiently delivering care or being wasteful? Why does the cost of hip replacement surgery vary by more than 4x around the country with no positive correlation between price and patient outcome? In fact, a higher price often is associated with a worse outcome. The US is the only country, other than New Zealand, that allows the advertising of pharmaceuticals to consumers. It's not surprising that more prescriptions are written per person in the US than anywhere else in the world. Patients can be quite persuasive in asking for drugs they see on television, in some cases where they do not even have the illness the drug is used for. Care variation was documented by Dr. John Wenberg at Dartmouth more than 40 years ago, and that variation in care across hospitals, clinics, and regions continues to this day. We are all not practicing medicine using the best available medical knowledge that delivers the best outcomes for patients. So what about the incentives? For the most part, a patient's out-of-pocket care costs, their copay and deductibles, are relatively small. Most of the costs fall to the employer through premiums set by their insurance company. The prices for services are very hard to find. Since patients are not paying the bulk of the cost of their care, and they are unable to easily compare prices, they choose service providers for reasons other than price. These include convenience, reputation, and those their physician recommends. In addition, as most providers are paid fee-for-service, they have an incentive to err on the side of recommending and providing more services that are necessary. Now, I'm not suggesting that providers intentionally order tests and procedures to increase their revenue, although there are cases where there were schemes to do exactly that. But an incentive is an incentive, and they mostly influence us without our knowing. That is why most hospitals do not allow pharmaceutical and other vendors to give staff members the most trivial items such as a pen, pad, or pizza lunch. They do not want their staff to make decisions that may be influenced by acceptance of gifts. I have described for you an overly costly healthcare system where the value obtained from all the money spent on care is considerably less than it should be.